We are now beginning week 3 in Intro to OT. This week we will focus on service models and settings. This week is focused on course outcome number 1, which states that you should be able to explore the scope of practice in delivery systems for occupational therapy. You will do this through various learning activities this week and in the next few weeks. More specifically, you must be able to do the following with respect to course outcome number 1. Take a moment now to pause the video and read through each one of these. Once you have finished reading them, you may start the video again. I want to emphasize the importance of the course outcomes. These tell you the purpose of what you're doing in the course learning activities. It helps you to connect what you're doing to what you should be learning. As part of the competency of explore the scope of practice in delivery systems for an OT, it is important to see the various settings in which OT practitioners can work, as well as emerging markets. Here are the 4 basic models and settings in which most OT services will be provided. We will now look at each one individually. The first model we will discuss is the medical model. This is the most traditional model in healthcare and in OT. There is typically a hierarchy of care and management, with the physician serving the role as the ultimate director of health. This model usually includes many teams and specialists and would be found in settings like hospitals, clinics, rehab facilities, and nursing facilities. Individuals seen for care in the medical model are called patients. In this model, the scientific inquiry method is relied upon. In this method, the patient is evaluated and given a diagnosis. Treatment is provided to the patient, and then they are reevaluated and/or discharged. These steps are the treatment process, and the aim is to end the problem or complaint. In the medical model, the OT practitioner operates under the doctor's orders. Many decisions about care are determined by third-party payers, like insurance companies, Medicare, Medicaid, and health maintenance organizations. In the medical model, OT might provide pre-surgery exercises and adapted devices for persons having knee or hip replacements. They might offer an outpatient hand clinic to provide therapeutic exercises and splints for carpal tunnel syndrome or tendon repairs. OTs will deliver rehabilitation services in a skilled nursing facility for post-stroke recovery under the medical model. Lastly, under the medical model, OTs assess and train with ADLs and psychosocial skills in acute care psychiatric. Next is the family care model. This is the primary model of care by most individuals because it is the model used before they enter the medical model. This is the model used when people care for minor health issues at home, when they practice good health habits, oversee normal development in family members, and engage in lifestyle management. The emphasis here is often on prevention, general wellness, maintenance, and meeting basic needs. The individuals receiving care are called family members. They could also be significant others. Some examples are caring for children or a disabled spouse, and there's often a clearly identified caregiver in this model. In the family model, the setting is usually the home, but can include settings like assisted living centers, group homes, and community-based residential facilities. There may be visits to the family care physician as needed, but the physician is not directing care as they are in the medical model. In the family care model, the healthcare professional plays a temporary role, serving the family by providing brief treatment, collaboration, and follow-up. OT may be involved directly, like through a home health agency, or on a consultative basis, like in providing caregiver training through a local senior center. The family model is very familiar to you, although you may not have identified it as such before. It occurs when a parent provides first aid to their child or makes sure their child gets their regular immunizations and dental checkups. It also occurs when an adult is caring for an aging parent in the home by learning how to manage their oxygen tanks, check blood sugar levels, or provide meals. Also under this model, an OT could meet with the recipient and their family in a hospice center to help with positioning and activities of daily living to improve quality of life and coping skills. The next model is the educational model. The primary setting of this model is in the school system, as the name implies. The persons receiving services are students. The emphasis here is on maximizing the educational performance of the student. This can be done through remedial programs such as speech therapy or environmental adaptations like assistive technology. No matter the student's impairment, physical, cognitive, or emotional, the services must be aimed at ultimately improving academic success. The OT practitioner is involved upon referral from the team or during developmental screenings. Team members may include teachers, special education staff, speech therapists, physical therapy staff, adaptive physical education specialists, and of course the parents and the student. Here are several examples of OT practice under this model. OT and speech therapy co-leads social skills and communication groups for students on the autism spectrum. OTs providing play-based and sensory motor interventions to children with OT as part of their individual education plans due to motor, developmental, or sensory processing deficits. OTs consulting with classroom teachers on handwriting skills programs. And lastly, OTs supporting transition initiatives for high school students with disabilities. The educational model is in schools only. The environment and scope of OT practice in this model is very specific. Educational does not simply refer to teaching clients things. We do that in all models of practice. In this model, OT is only involved if the student, who is typically age 3 to 21, has a physical, emotional, or cognitive status which interferes with their ability to learn in school or participate in educational activities. So if a kid breaks his arm and can still manage his studies, get around the cafeteria fine, can still type or write, and he may briefly attend adapted Phy-Ed, then there's probably no need for OT services in the educational model. He might be seen by an OT at the outpatient clinic or doctor's office for splinting and exercises, but that's the medical model then. In the schools, OT, PT, and speech can only see the child and be part of the individual educational plan if the problems interfere with academic performance or extracurricular activities. The last model is the community model. The overarching premise of this model is that the individual is empowered to act on his or her own well-being, health promotion, and prevention. The persons being served can be individuals, in which case they are called clients, visitors, or consumers, or persons being served can be groups of people, in which case they are called organizations or the public. OTs and other public health professionals partner with consumers to provide resources, education, and consultation with the ultimate goal to enable them to care for themselves. OTs may also be advocates and activists for system or political changes. One example might be motorcycle helmet laws. Settings where one might see this model in action may be public programs and initiatives, community centers, county health programs, senior organizations, faith organizations, and others. Some examples you may be familiar with might include county immunization programs, support groups, Alzheimer's education series, health fairs, smoking cessation programs, and others. This is a picture of a car fit event put on by the Western OTA program with one of our community partners. I want to make an important point. To do that, let's take a look at the example of the tobacco cessation program. OT practitioners might be involved in teaching alternative relaxation techniques and stress management as part of the whole tobacco cessation program. Let's say community members participate through their local community center. In this case, it's the community model. Let's also say that through their participation, community members stop or decrease their tobacco habits. As a result, we see less persons diagnosed with lung cancer in the doctor's office and less persons placed in nursing homes with chronic obstructive pulmonary disease. This is the medical model. In addition, we see an ease on the burden of care for caregivers in the home who care for people with lung-related problems. This is the family model. Finally, perhaps we see less asthma-related problems which affect participation in gym classes. This is the educational model. One thing to know about the community model is it seeks to get at the root of the problem and promote the well-being of the whole population. The community model can occur in many sites. You must examine the overarching goals and target audience to know the model being used. Next, we're going to briefly introduce OTA practice settings. I will introduce it here and you will complete other learning activities this week which will give you more information. There are many settings in which OTAs can work. There are traditional settings like hospitals, clinics, and skilled nursing facilities. OTAs work in schools. OTAs may work in people's homes or places of work. OTAs can also work in community settings. There are many exciting possibilities from traditional to innovative. Here, we will look at where graduates of this program work. Each year, we ask OTA graduates to share their employment information 6 months after completing their degree. You will also get the opportunity to share this information when you graduate. Here are some examples of reports from recent years which indicate work trends for our graduates. You may take a moment to pause the video if you want to look at this closer. I also want to highlight emerging practice areas. The AOTA continues to look at the horizon of the OTA job market. They have identified emerging markets for the OT practice, which means opportunities for practice in these settings are growing. Ones you might see as emerging practice areas are low vision, fall prevention, dementia care, universal design, driving and community mobility, school to work transitioning, and many others. The Wisconsin Occupational Therapy Association conducted an informal survey to see in what diverse areas OT practitioners were working. These unique job areas were identified. This should give you some inspiration. Take a moment to read these, and you may want to pause the video. As you can see from this lecture and the resources you will access this week, there are a variety of opportunities and models in which you can practice. Once you have your basic OTA education, you can build on your own experiences, skills, and interests to follow your passion. Your next step after viewing this lecture is to go to Blackboard Week 3 and view the resources under Job Description Resources and Occupational Outlook Handbook website. This concludes this lecture. I hope you find the next resources interesting and informative.